why don't you start us? Tell us when.
Okay, you should be good to go.
Okay. Hi, I'm Kathleen Digre, and I'm a professor of neurology and ophthalmology. And you're at headache school tonight to learn about headaches due to high and low pressure. And this is sponsored by the Department of Neurology here at the University of Utah, and also co-sponsored by the Danielle Henry Foundation, the Shine Her Light Foundation. I want to first make the point that the headaches I'm going to talk about tonight are not common. They're not rare either. They're not rare, but they're not common. If you take all headaches, most headaches, and you see this pie chart here, this big pie chart, most headaches that are in the red are migraine, tension type, cluster headache. That's what most headaches are due to. But there is a proportion of headaches that we call secondary headaches, and these are due to high pressure, low pressure, tumors, infection, all kinds of other things, okay? But they're rare. They're not the most common headache type. So the question I know all of you want to know is, how do I tell whether I've got just a migraine, tension type headache, or whatever, compared to a secondary headache like high pressure or low pressure? And so there's some features that help us know whether it's a secondary headache or a primary headache disorder. And so in primary headache disorders like migraine and tension type, they usually run in families. They're usually typical headaches because, and for migraine, it's light and sound sensitivity, nausea and or vomiting. And for like cluster-like headaches, they have autonomic features, meaning it's usually unilateral with a droopy eyelid or runny nose or tearing or something like that. Those are typical primary headache disorders. And secondary headaches, however, those headaches that are not as common as the primary headaches, they're usually new onset, something different than anybody's had before. And then there are features at each of the headaches, the high pressure and the low pressure, and we're going to talk about those tonight. For example, some headaches are only present when somebody's upright, and when they lie down, it goes completely away. Well, that's a feature of a low pressure headache. Sudden onset of the worst headache of one's life, that for a neurologist or a primary care doctor should trigger something is wrong in the brain and we have to do something about it. Noises and symptoms that come with the headache, like whooshing noises, weakness, numbness, inability to walk, a droopy eyelid, double vision, blurry vision, those should trigger looking for a different kind of headache, for a secondary headache. And then sometimes people who have headaches with fever or fatigue. Now fatigue is a pretty general one, but new severe fatigue should lead somebody to look for a secondary headache cause. Most headaches are primary. There's some headaches that are secondary, and the ones we're talking about tonight are secondary headaches, and they are not as common. So tonight we're going to review the characteristic symptoms and signs of high pressure headaches and low pressure headaches. And we're going to look at the imaging findings, what helps us tell what's going on in the brain and you're going to see that there's a process that we have to go through to come up with the diagnosis properly. And I want to stress this point. You should always talk to your provider about your concerns. If you think you have one of these headache types, you should always talk to your provider carefully about your concerns and tell them that person what they are. So to understand headaches and pressure, you first have to understand a little bit about the brain, okay? And about how you get high pressure or low pressure. And the brain, this is a cartoon of the brain, and this is the brain itself. This is like the back of the brain, the cerebellum, the brain stem. And the spinal fluid is made by these little choroid plexus that live inside the brain. They manufacture spinal fluid, or CSF. And that percolates and goes all over the brain and the spinal cord. And it's amazing how much spinal fluid is made every single day, like a pint a day. And the volume in our spinal fluid is made up. Every 6 to 8 hours, it's refreshed. So it's a process that's going on. You don't have to do anything about it. It's just doing it by itself. A normal pressure is between 70 and 200. And we talk about millimeters. We use the metric system, millimeters of spinal fluid pressure. And that gives us what is normal. I'll talk a little bit about what is the normal pressure. And the most important contributor to the pressure is what happens in the veins. Now the veins also cover the brain. There's a big vein that goes across the top. There's one that drains the brain. The arteries come in and give the brain blood, but the veins have to take the blood out of the brain. And the brain, you can't imagine how much oxygen and nutrients the brain uses all the time to just function, a lot. And that vein has to take all that stuff out, that out, and the spinal fluid is also taken up by what we call a little arachnoid granulations. They're little kind of cauliflower looking things that fit into the veins, and they have to pump some of that spinal fluid out, because let's say you make a pint, and then if you're going to make another pint, you better get rid of a pint. So you've got to have a way to kind of circulate the spinal fluid. So these are the veins that I was talking about. They're all around the top of the brain. They're kind of by the cerebellum. There are deep veins that drain internally. And then these arachnoid granulations where they push out the spinal fluid kind of sit in the veins to kind of push it out to get rid of it. So I know that's a lot of anatomy and physiology, but when we talk about pressure, we have to understand where the spinal fluid comes from, what constitutes making the pressure elevated or low. Now, what is a normal spinal fluid pressure? If you take a whole bunch of people, and this study they took about 250 people, some people have pressures about 60 or 80, and some people have pressures way up in the 200 to 250, 300 range. And these are normal people. So our pressure varies from individual to individual, and it can vary from time to time. It can be higher when we cough or sneeze or have a bowel movement or bear down, and it can be lower when we're just sitting quietly. So it can vary a little bit through the day. So, but normal is kind of in this 180 to 200. We say 250 if you're overweight or obese. A normal pressure is usually kind of in that range. That's what a normal pressure is. Now I'm going to take you through a typical case of a high pressure problem. So this is a 32-year-old woman. She'd have an occasional migraine, but not anything serious. And then she started getting new headaches, and her migraines started to worsen in addition. And then she started getting double vision, and then she started hearing a whooshing noise in her head. And often the kind of obesity that's associated with the high pressure is more of a pear-shaped obesity than apple-shaped. So she went to see her doctor, and they diagnosed idiopathic intracranial hypertension. Now, the high pressure symptoms and syndromes are also kind of like the primary headaches and secondary headaches. The idiopathic intracranial hypertension or pseudotumor cerebri syndrome can be primary or secondary. That means that something can cause the pressure to go up. And so that's why we do imaging. Hydrocephalus can make you have high pressure in your brain. A brain tumor can look just the same. Meningitis. If you've got meningitis, your pressure can go up. If you've had severe trauma to your brain, your pressure can go up. There are drugs that can cause the pressure to go up. Antibiotics like tetracycline and minocycline are drugs that can make your pressure go up. Vitamin A can make your pressure go up. polar explorers in the early days, when they would eat polar bear liver, they would come down with high pressure headaches. There are certain systemic diseases that can do it, and then if you obstruct your veins, venous sinus thrombosis, if you aren't getting rid of that spinal fluid, your pressure can go up. But if you take all these secondary causes, they're not as common as this condition, which is the idiopathic intracranial hypertension, which means that there's no cause to it that we understand except for obesity and maybe genetics. And we'll talk more about the causes. Now, what are the clinical characteristics of the headache associated with increased intracranial pressure? Well, the most common type is tension type headache, which means a dull headache. So it sounds like it's a tension type headache. And the classic teaching tells us people wake up in the morning and they have a worse headache, and headaches with Valsalva. Valsalva maneuver is like if you're straining to have a bowel movement or you're bearing down. That's what we call Valsalva maneuver. However, many times the headache of high pressure is indistinguishable from migraine. People can have nausea, vomiting, light sensitivity. And that's why we sometimes, the headache type isn't very helpful, whether it's high pressure or not. The severity isn't helpful. The change in frequency isn't helpful. The presence of an aura isn't helpful. The response of treatment isn't that helpful. About a quarter of normal people who get a lumbar puncture and have a headache will get their headache better with the lumbar puncture. So lumbar puncture, saying your headache goes away if you take fluid off, isn't necessarily helpful. What is helpful is if you have symptoms of pulsatile tinnitus, like whooshing noises in the head. Obesity, if somebody is obese, sometimes those people are at higher risk to develop this high risk, to develop the intracranial hypertension. And then blurred vision or transient visual obscurations, where your vision dims out for a period of time and then it comes back. Those are more helpful than just the kind of headache you have. Now, what are the symptoms of high intracranial pressure? Headache is the most frequent symptom. TVO means transient visual obscurations. These are dim outs of vision that you can just be sitting there and your vision dims out. Back pain is very common. Dizziness is common, and these are common with migraine too. Light sensitivity or photophobia, the whooshing noises in the head, neck pain, and especially pain between the shoulder blades, visual loss, changes in cognition, double vision, and pain that goes down into the arms. Those are the symptoms that come with these people who have high intracranial pressure. How do we recognize that somebody has this as a problem? Well, we have to look in the back of the eye. We look for papilledema, disc swelling, okay? And I'll talk about what that is, okay? Now, the problem with that is that some people have optic nerves in the back of their eyes that are just funny-looking nerves and can be mistaken for papilledema. So they have anomalous nerves or pseudo-papilledema. Usually the visual acuity is normal, but some people have double vision. So what are we looking at? So when we see somebody, we're going to use an ophthalmoscope or a device to go in to look in the back of the eye. And what we're doing is we are looking through the eyeball to look at the back of the eye. And this is where we're looking, is at the optic nerve. On this cartoon you can see, here's the eyeball, here's the optic nerve. And this is what swells, because when the pressure goes up, it keeps the fluid from being transmitted, and there's a backup of fluid on the disc, and it gives you this swollen disc, and I'll show you what that looks like. And the more papilledema you have, the more likely it is that you're going to lose vision. Now, I hope you can see this, but there are different grades of papilledema as well. This person had a pressure of 340, so definitely high pressure, but very few signs of papilledema. So some people can have this condition without having papilledema, but they have other signs that go with it. And then some people have a low-grade swelling where it swells at the top and the bottom. Some people have higher grade swelling, and like this person had terrible swelling with swelling all around the nerve. Okay, so this is more normal. This is very abnormal. Can you see that? I hope that's visible to you. Now, so we use what we see in the back of the eye a lot, and that's something that has to be done. You have to have an eye exam and often a visual field and things like that. We also look for other conditions that will make the pressure high besides that idiopathic, that list of secondary causes that we look for. One condition is sleep apnea. Sleep apnea can raise intracranial pressure and cause the pressure to be elevated and can also give more headaches. A severe anemia, so we always make sure that the person is not anemic. And then those medications, tetracycline, minocycline, vitamin A, growth hormones sometimes can raise intracranial pressure. Sometimes steroids like prednisone use can increase intracranial pressure. And one of the most important ones is that venous sinus thrombosis, because the veins are trying to drain the CSF, but if they get blocked up or have a big clot in them, they can't drain the spinal fluid. We always look for a brain tumor in this condition to be sure there's not a true brain tumor. And then we look for metabolic problems. Sometimes parathyroid disease can cause disc swelling and elevated pressure. How do I know that I don't have one of these things? I'm sure you're asking yourself that question. Well, first, somebody has to take a history and ask about these questions. And these are the important questions to talk about. The second thing we have to do is get imaging. And if you've got to have imaging in any high or low, if you suspect high or low pressure, you have to have imaging because there's some telltale signs that we look for on the imaging that help us see what's going on. So for example, in this person who had idiopathic intracranial hypertension, what I noticed on her imaging was that she had a dilated nerve sheath. So where the optic nerve came into the globe, there was extra spinal fluid. The white here that surrounds this nerve is all spinal fluid going in and pushing on the eyeball and causing the optic nerve to have swelling. And I look for flattening of the globe as well. On this is one kind of image. Another image that we do all the time is a sagittal image. And this will be important when we talk about low pressure, but in high pressure, we look for what's called an empty sella. The pituitary sits here normally, but when the pressure is elevated, it often pushes the pituitary off to the side, and it gives us a sign of high intracranial pressure. So I look for the flattened globe, the dilated nerve sheath, and the empty sella, which can occur in people who have high pressure. Now, the real bad actor that we always look for is that venous sinus thrombosis, because those people who have that can look identical to the idiopathic intracranial hypertension, but they have a big fat vein that's clotted off, or I can see a clot in their vein, or we do an MRV and there's no transverse sinus. So we have things we look for in people who have high intracranial pressure because we want to make sure we're not missing a secondary cause. This problem we treat with blood thinners, and it gets better. And I'll talk about the treatment of the high pressure as well. So first it's the history, to ask all those questions. The second thing we have to do is image people, because we got to know what's going on inside the brain. And the third thing we have to do is a spinal tap. Now, a spinal tap is done in a supine or a lateral decubitus position. In other words, you lay on your side. A needle is introduced below the spinal cord, and then we put a manometer on here to measure the pressure. Okay? And as I said, a normal pressure is usually less than 250 millimeters of spinal fluid. The fluid itself we send to the lab to make sure there's no meningitis or infection in there that could cause the pressure to be elevated. Sometimes people say that the lumbar puncture helped reduce the headache. And as I told you, that even in normals that can be helpful, but in people with high pressure, it can definitely reduce the headache. Now, the one association with the high pressure that has been across the board is obesity. People who are obese are more likely to have this condition. And if somebody has the condition, 80 to 90% of those people are overweight or obese. And weight loss does improve this condition. And obesity and being overweight has many different comorbid conditions, like orthostatic edema syndrome, increased venous pressure, sleep apnea, polycystic ovarian syndrome, and metabolic syndrome. These are syndromes that happen a lot with people who have raised intracranial pressure and obesity. Now, a lot of information we get is from research. And the first big research study done in the United States for idiopathic intracranial hypertension was the Idiopathic Intracranial Hypertension Treatment Trial. And it was published 4 or 5 years ago in a very reputable journal. This study took place across the entire United States and Canada, and the University of Utah was a site. We enrolled patients and into this study, and we participated. As you can see, most of the patients were on the East Coast and the South, and a few in the West Coast. So we kind of covered this region of the country, as we always do in Utah. And we learned a lot about the headache associated with high intracranial pressure. First, we learned that headache is present in 84% of the people who present with the condition. And all the people who were entered in this study were diagnosed because they had papilledema, they had a normal MRI scan, they didn't have venous sinus thrombosis, they didn't have any of those other things, they had the idiopathic form of the condition. Surprisingly, 41% already had underlying migraine. The general population for women, less than 20% of women have migraine. 41% had migraine in this population, so this is very interesting. Now, the headache phenotype, and when I use that word phenotype, I mean what does that headache sound like? Well, it sounded like a migraine in 52% of people, or probable migraine in 16%. So, you know, that's like almost 70% of the people sounded like they had migraine. Another 22 to 26% had tension type headache. About a half of the people who were in our study had medication overuse, meaning they took medicines that were actually acute rescue medicines that could be giving them a headache, like a non-steroidal or acetaminophen with caffeine or something like that. They had high HIT6 scores. HIT6 is a disability. How bad is the headache? And their quality of life was reduced. And as the headaches got worse, the quality of life got worse. But here is an interesting fact. The headache disability did not correlate with how high the pressure was. So they could have really, really high pressure and not much headache, or they could have kind of medium pressure and horrible headache. So this pressure does not correlate with how bad the headache is. It didn't correlate with how much weight they gained, their body mass index, or how obese they were, whether they lost weight, whether they had papilledema, how bad their papilledema was, or their visual field. So the headache disability is kind of separate from the pressure and all these other factors. And it makes it even more frustrating to treat. There's no difference between the pressure and those with or without headache. So people without headache could have really high pressures, and people with headaches could have kind of lowish pressures. So that's a frustrating piece that, and I think that is what frustrates a lot of people who have headaches associated with high pressure. We did find out that weight loss did help, 10%, and this is also helpful in people with chronic migraine. Medications that lower pressure also helped. Acetazolamide was what we studied in the IIHTT. Other carbonic anhydrase inhibitors and diuretics may help. What we do know is the best headache treatment is probably a diuretic and a migraine preventative treatment. Frequent lumbar punctures, some people go for frequent lumbar punctures because it really helps their headache. And a study that was done on that showed that it may help the headache, but there's a lot of problems with it. You can get a low pressure headache afterwards too. And you want to watch the use of medications that could increase weight, and you want to watch for medication overuse. And the other thing is, a lot of people, we have to worry about people wanting to get surgical procedures done, because if you've got bad headaches, you're willing to do almost anything. And you don't want to do things that are going to cause you harm down the road or that are not necessary. So the best treatment for people who have intracranial, high pressure, and headaches, a diuretic, usually acetazolamide, and a migraine preventative. We often will use topiramate or Topamax because it helps with weight loss in addition to lowering intracranial pressure. Propranolol, tricyclics like amitriptyline, nortriptyline have been used. Valproate causes weight gain, so we don't like that one. Non-steroidals are sometimes helpful. Verapamil is sometimes helpful. Now, if people are losing vision, we can recommend surgical treatments. Some people want surgical treatments just for the headache. And that I want to just talk about what surgical treatments are out there. So the lumbar puncture can be done, but remember the spinal fluid will return in a few hours. They used to take off, it's called subtemporal decompression. They used to take out part of a skull. And I mean, can you imagine how horrible that must be? And they had so many complications that's never done now. The major procedures that are done now are shunts, optic nerve sheath fenestrations or decompressions, stents in the veins, and gastric bypass. And I'll talk about each one of these briefly. First, they do shunts. A shunt is where you put a catheter up in the spinal fluid, you run it down under the tissues, and you put it into the abdomen, and it drains the spinal fluid. The shunts these days have programmable valves, so you can dial in a pressure. The problem with shunts is they usually fail, or you have to have multiple revisions. It's not a panacea. They fail in the lumbar peritoneal shunts, where they just did one from the lumbar to the peritoneum or to the abdomen. They failed about 96% of the, 86% of the time. The ventricular peritoneal ones fail about 44%, and obstructions of the shunts can also occur. So that's one option. The optic nerve sheath fenestration, this is an eye, and they go behind the eye, above the eye, on the side of the eye, and they go back behind it and then make a little fenestration around the optic nerve and let the spinal fluid out. It usually works to prevent the person from losing vision. It's not available everywhere as a problem, and there can be complications, and sometimes this doesn't help with the headache. And then we have a trial going on where we are another site. It's called the SITE trial. It's a surgical intervention for intracranial hypertension, and it's going to compare better medical therapy, optic nerve sheath fenestration, or the shunt to see which is the best treatment. And we've got that trial ongoing at the University of Utah. Gastric bypasses work great for weight loss. It doesn't protect vision, but for weight loss, there's lots of different surgeries. Many of people who are obese get this because they've got diabetes, metabolic syndrome, sleep apnea, hypertension, etc. But it's not a treatment for visual loss or headache per se. The stenting is a procedure where they go in and put a stent. So sometimes people who have high pressure have narrowing of their venous sinuses, and the idea is to open up the venous sinus, but you're adding a foreign object into your vein, and then they can get little stenoses elsewhere. So, but it is a procedure that has been done for people who have been refractive to all types of therapy. You can find more information on the novel website. This is a partnership between the North American Neuro-Ophthalmology Society and the University of Utah Eccles Health Sciences Library. Go to the patient portal and go to the condition pseudotumor cerebri, and there's a page that takes you to patient information brochures, literature searches, support groups, etc. And this is one of our handouts on the pseudotumor cerebri syndrome. So that's a place to get more information on high pressure headaches. Anybody have any questions about high pressure headaches here that's in our audience today?
The list of drugs that you had up there,
Okay.
how would a drug like gabapentin fit into that list?
It would be a headache preventative.
Okay.
So the diuretic would lower the amount of spinal fluid being made, and then the gabapentin would be given for the pain.
For the pain, okay.
Okay, that's how that would fit in there.
Okay.
But good question.
Okay.
Okay. Now what about low pressure? Well, that looks a little different. But this is a 32-year-old car salesman, and he was a weightlifter, and he lifted weights every day before he went to work. And one day he lifted weights, and he had a new daily persistent headache. He had a headache that started and it didn't go away. And he told me the date that it happened. And the characteristic of this headache is when he was lying flat, he was fine. But when he was upright, his headache got worse and worse and worse. In fact, to the point where when I went in to see him, he was lying on the bed and wouldn't get up. I mean, I almost had to examine him lying on the floor, you know. And they can get nausea, vomiting, numbness, vertigo, and often the neuroexamination is normal, okay? So that's the history of somebody with a low pressure headache. Now, there are typical imaging findings, and we'll talk about all of them, but when I did his imaging, he had a narrowing around his brainstem. He had enhancement around his brain, and this I don't know, I hope you can see it, but his whole back of his brain, the cerebellum and the brainstem were kind of smushed together. And that's very typical of low pressure syndrome by imaging criteria. So the workup we did, we tried to do a lumbar puncture. He had no pressure, and there was no abnormality on his spinal cord. But these are leaks that occur around the spinal cord. I'll show you a picture of that. We did a blind blood patch. We did a blood patch where you, and I'll show you how that works too, where you take blood from the person and then introduce the blood to kind of close up a hole. And we tried many, many different things. We had to do a myelogram. A myelogram is where you put a dye into the spinal fluid column to look for where the leak is. And you could see he had a leak that occurred here, and we could see the leak. So we knew where the leak was so that we could patch the leak right where it was. And then they patched the leak. He laid flat for 48 hours, and his headache went away. So it's important to diagnose this headache because we want to make sure that this, you know, because these can cause really tricky headaches. Low pressure can cause tricky headaches. So the history is really important. This is, again, where the provider has to really ask a lot of questions. It was first described many, many years ago, 1938, by a guy named Schultenbrand. He called it allocuria, which means low fluid. And he was the first to observe that it was really a low fluid state, not a low pressure state. So it means that the fluid is draining out, so the brain doesn't have any of that fluid cushioning it, and it's unhappy, and it gives you that headache. Other names that people talk about are hypovolemia, spontaneous low pressure headache, low CSF volume headache, hypoallouric headache, orthostatic headache, intracranial hypotension. All these words are the same thing, low pressure headache or low volume headache. Now, there are two kinds of low pressure headaches. There's the primary ones. These are spontaneous. They happen, and I'll tell you what can cause them, but they're spontaneous. It's not like somebody did something to somebody to make it happen. Now, if you ever had a spinal tap, that can give you a low pressure headache. So a spinal tap is a typical cause of a low pressure headache, and that's a very, very common post-lumbar puncture problem. And then there's all kinds of other things, like if you have a shunt in your head and you overdrain it, you're going to get a terrible low pressure headache. Surgeries around the spine or around the brain can cause this low pressure headache. Sometimes sinus surgery, they go in and nick the spinal, they go way too deep, and sinuses, you know, that like we've got lots of sinuses, and the people get aggressive and they go after sinus surgery, and sometimes they can inadvertently enter the cavity, the skull, and cause a leak. And then if you're injured by an injury and your nerve root gets pulled out, you can get a leak. So these are the kinds of low pressure headaches. The most common low pressure headache is a post-lumbar puncture headache. That's the most common cause of a low pressure headache. Now, how do we recognize somebody has a low pressure headache? Well, we have to look at the history. Usually they're typically severe headaches and neck stiffness. And one of the key pieces is that it's better lying down, worse when they're upright, but there are a few people who have it paradoxical, like they're better when they're upright and worse when they're lying down. After you have this for a long time, it doesn't matter if you're down or up. It's there all the time. But at the beginning, a typical headache is upright, it's bad, lying down, it's better. It can be throbbing, so it can sound like a migraine. It's often intense. It can be bilateral, it can be occipital, it can be anything. And it gets worse with coughing, sneezing, straining, or having a bowel movement. And the story that people come in with this can sound like what we call new daily persistent headache, which can be the phenotype or what that headache sounds like. It started one day and it never went away. A lingering daily headache with neck pain and pain between the shoulder blades. A chronic daily headache following an orthostatic headache, meaning that they came in and they had a bad headache when they were upright all the time, and then finally it didn't matter whether they were up or down, they always had a headache. An exertional headache and an intermittent headache can cause by an intermittent leak. Now, how are we going to recognize it? Well, first the history again. That's why providers have to talk to the patient and get the information. And then we have to look for the signs. So this headache is more common in women than men. The peak time is around 40, but it can occur anytime. There's no disc swelling or papilledema. There is a test that we sometimes do called a Trendelenburg test. That means we put the head down, the legs up, and after 5 minutes and see if the headache gets better. Because you can imagine you're kind of increasing the pressure in the head a little bit, so if you've got low pressure and you increase the pressure, it might make the headache better. It's not a perfect test, but it's something else. The people who tend to get this are people with a lot of double jointedness or this, flexible joint, like gymnasts. If people were gymnasts, they're more likely to get this kind of thing because they can do all these weird things, and people who can touch their thumb to their, all that stuff. So those are the people that are at a little higher risk for getting this low pressure headache. Now the risk factors for getting this, we already talked about lumbar puncture and trauma, but there are people who've gotten this spontaneously from water sports, weightlifting, golf, a cough from an upper respiratory infection, chiropractic manipulation, motor vehicle accidents, fishing, casting, yoga, funny positions, and then these hypermobility syndromes like Marfan's, Ehlers-Danlos. So these people who have joint hypermobility or hyperelasticity of the skin are at higher risk for the development of this kind of headache. So these are risk factors for development of it. So how do we make the diagnosis? Well, we do the history. Then we go for imaging. Now, what we look for in the imaging is more on, this is a sagittal section of the brain. And remember I showed you, the whole brain stem and cerebellum are all smushed together, like they're coming together. And then the bottom, the cerebellum is kind of going through we have a hole that the spinal fluid and spinal column should be going down. And the cerebellum is heading down by the spinal cord, which is not normal, okay? And then there are many other findings we look for. We look for whether the optic nerve is slumped and the pons is flattened and the chiasm is straight. And so we look for a lot of different things when we're looking for this. The pituitary becomes plump because it gets engorged. And then we get dilated veins that cover our brains. And that's very typical for this. Now, this is an important point about recognizing low pressure syndromes. This was a 23-year-old woman who had chronic headaches ever since she had her delivery 2 years ago. She did have an epidural, that's where they go in and put numbing medicine in, and she developed chronic double vision. And this is her image, and you can see that the tonsil is hanging down into where the spinal cord should be going, and it shouldn't be down that flat. Her pituitary is plump, her pons is flattened, she's got that kind of squish thing. And we diagnosed her with the low intracranial pressure. She was first diagnosed with Chiari malformation, and that was not a Chiari. So when we fixed the leak, you can see how it went back to normal. Can you see the difference now? This tonsil came back up. There's more room for her brainstem. It doesn't look all squished together. And so this is what if you find the leak, then you can get rid of these findings and have the brain go back to normal. Now, this is an important point because a lot of people these days are getting diagnosed as Chiari syndromes. And so a Chiari syndrome is a congenital defect where the cerebellum goes down by the spinal cord. But it's the way the person is made, and but it can look just like the spontaneous low pressure headache syndrome. And so here's a case of the low of CSF hypovolemia, but it can look just the same. It's just that you have to look at the imaging findings carefully. In this situation, there was an empty sella. This person also had a syrinx and some other things that go along with Chiaris. And headaches can be very common with the Chiari. So it's really important that somebody, before they start decompressing the Chiari, because if you decompress low pressure, you can make that worse. You can make the low pressure headache worse. So you don't want to do surgery for intracranial CSF hypovolemia. What you want to do is find the leak, okay? Sometimes the pressure is low in this situation, but a quarter of people had normal pressure between 90 and 130. Sometimes their spinal fluid showed white cells or protein elevation, but sometimes the spinal fluid is normal. We don't usually do a lumbar puncture in this situation. What we do, however, is this myelography, where I told you we put the dye in and then we look for the leak. And you have to image the entire spine. Interpretation can be very difficult because sometimes the leaks are too fast or too slow, and then sometimes you can't find the leak. About half the time we don't find the leak, which is very frustrating because it's hard to patch something you can't find, okay? So here are typical findings in people. A lot of people have these great big pockets of spinal fluid. They're called Tarlov's cyst, and they come off here's our spinal cord, and the myelogram shows these big pockets of fluid coming off of the myelogram. So what we do is a blood patch. Now what is a blood patch? Well, we take blood from the person. So here's a syringe. We've taken blood from the person, and we introduce it through, here's this end of the spinal cord, and we put a blood patch right over where we think the leak is, or sometimes we do it blindly in the L4-5 space because we know the spinal cord is way up here. We don't want to put a needle into the spinal cord. So, but the blood patches, sometimes we do it blindly, meaning we don't do it with X-ray guidance, we just put it in. Sometimes we direct it. Sometimes we repeat it with big high volume patches to close up the leak. Sometimes we do multiple patches. But that's what a blood patch is. Now why does a blood patch not work? Sometimes the leaks are too big, or they have too many of them, or they're too fast, or they're too slow. And then another frustrating one is sometimes the spinal fluid just goes right into the vein around the spine. And then those are really hard to find. Sometimes we can do medical therapy like bed rest. Caffeine is very helpful for low pressure headaches. IV fluids, steroids sometimes help. Abdominal binders, these are these big kind of corsets that put around the abdomen to kind of increase the pressure in the head. Vitamin A has been tried. There are many other medications that have been tried to increase the pressure. IV aminophylline, caffeine, theophylline, theobromines, etc. have been used to try to increase the pressure. But there are many other treatments like epidural saline infusions. Sometimes we've had to recommend surgical corrections of these leaks because we can't find the leak. And then sometimes we occlude the draining vein. And there are many, many other treatments that have been used for this syndrome. Now, I do want you to know that the American Migraine Foundation has a wonderful website. If you're not a member, you should become a member immediately. Because they have all kinds of information, and they have a great handout on what you need to know about low pressure headaches from Dr. Deborah Friedman, who's a specialist in intracranial hypotension. But this website is excellent, AmericanMigraineFoundation.org. It has lots of information about headache and migraine. Become a member. They have newsletters. They've got a Facebook page, Move Against Migraine, etc. So this is the world of pressure and headache, and I wanted to make sure I saved a little bit of time to answer any questions or talk about anything about headaches of any kind. I'm happy to answer, even if it's not about high pressure or low pressure headaches, I'm happy to answer any questions that you might have. Yes?
This is not about high or low pressure, but it might be, but I was curious, and that's why I came to hear what you had to say tonight.
Yeah.
In visiting the pain clinic regarding my long time migraines, it was recommended that I might try massage to reduce tension that might reduce headache. So I went to a very well-recommended massage therapist 4 times, and twice I got incredibly sick and threw up and got vertigo and dizziness, and it commented to me that it might be something to do with the brain stem, and I thought, is that low pressure or high pressure? Can you tell me anything?
I can tell you about that. So I'm going to repeat what you said, kind of summarize. I hope I summarize it correctly for our at-home audience, okay? So she's had chronic headaches, and she went to the pain center and they recommended some massage. She had massage done, and it caused severe nausea, dizziness, to the point where she threw up and everything else. And the therapist said maybe this is a brainstem problem, or it's happening in the brainstem. So that's true, and could it be related to pressure? And the first answer is I doubt it's related to pressure, high or low. But let me tell you how, so when people have migraine, and especially chronic migraine, they've got sensitive brains. And that brain is sensitive to all kinds of stimuli. They're more sensitive to pain anywhere, light anywhere, sound anywhere. And if you have input like massage input, that does connect with the spinal cord and into the brain stem. And the brain stem has dizzy centers that are nearby the brain stem. I mean, they're in the brain stem. And people who have migraine often get more dizziness. So this is a very common phenomenon. And people who get massage, sometimes it's so deep and therapeutic. It's too therapeutic because it causes more pain, and then that can trigger migraine headaches. And then the migraine headaches can trigger dizziness and have these other things associated with them. So I've heard this story many, many times before. It's not rare, but it doesn't mean your brainstem is bad. It just means you probably have migraine, and that the pain that was generated with the massage therapy can sometimes trigger really bad migraines and even trigger dizziness and vertigo, which is very common accompaniment to migraine. So that's not rare. It's not, that symptom you had is not rare, but it's not probably related to pressure, either high or low. That's not one of those symptoms. But that's a really good question because that's what people want to know, is could this be related to pressure? Yes?
So where do you start with someone who's had headaches and migraines for long periods of time? They're not something that's just started randomly with like the high or low pressure, but it's been constant.
Okay. So when people, the question is, where do you just start with chronic headaches and chronic migraines and all this kind of stuff? The first place you start is working with your provider to come up with the history, because the history is what's going to tell us what's going on, okay? And that history starts with family history, life history, what's happened, when did the headache become really severe, could there be something that spurred this headache to become bad? And a provider should also be looking for clues of secondary headaches. You know, is there something else going on? And it's those questions that, you know, is this, how did it start? Was it positional to start with? And kind of look at that. Many people get scans and imaging, and frequently looking at imaging. And that's where you want somebody to take the whole history, do a careful exam, looking in the back of your eyes, doing a complete neurologic examination, and then looking at the imaging and looking at the whole story and coming up with the diagnosis. The problem for migraine and headaches is, you know, most of the time the imaging is normal. And we don't have a Dr. Seuss machine that we can put people in and have you come out and with a big label that says, I have a high pressure headache, I have a low pressure headache, I have migraine, I have chronic migraine, I have tension type. Do you know what I mean? I love that machine. I love that machine. But we don't have it. So we have to talk to people, and it's how this whole story goes is really what is going on. Does that make sense? And that's the important thing is learning everything you can about migraine. That joining the American Migraine Foundation would be a really good way to get more information. Talking with your provider. We've got a section in headache school here on how do you talk to your doctor about your headaches and you know, what can you do? And there's lots of resources out there, and of course sometimes providers want to refer people onward to get more help from headache centers or from neurologists or something like that. But that's how you tell. It's with history, examination, and then looking for those clues of what else could be going on that could be happening to make your headaches worse. Anything else? Yeah.
One of my kids had an MRI with an empty cella.
Okay.
And you mentioned that?
Yep. Okay, so empty cella is one of the findings we look for high intracranial pressure. But many times people can have that empty cella with no elevated intracranial pressure.
Okay.
It's
That's
just,
the question.
yeah, so it can occur in normal people. Why does it occur? We have no idea. But for some people it's probably the way their CSF percolates and circulates around, and for some people they get it and some people don't have it. I mean, it is one of the findings we look for on high pressure, but it's not the only one we look for. And if it's an isolated empty cella and has no other symptoms of high pressure or anything else going on, or signs of papilledema, then it's probably not, it's probably incidental. But that's a very good question. Any other questions from?
Well, it was my younger child, so he was, he's 10, and he gets migraines occasionally. So,
Yeah,
but
and
my older son has chronic migraine, but his MRI was normal. So it's the same thing.
well, and it's probably not pressure, it's probably migraine and chronic migraine.
Yeah.
And you had a son that's 11. We have a nice panel discussion about pediatric migraine in headache school. So that would be one that you might want to listen to, because it really talks about headaches in children. And we'll be, I think in April or May, we have another bunch of pediatricians coming to give us a lecture. So we have lots of information, and we want to hear from all of you, even you at home. If you have something you would like us to present, just give us an idea, and we will get an expert to come and talk on that topic. We're very happy to do that. We have many basic lectures, and then we have more advanced lectures, and we have lectures about things that are not normal, you know, like high and low pressure. That's not very common, but it's important to know about because it's a kind of headache that's out there too. Okay, well, thank you guys for coming, and we're going to be having headache yoga to follow. So if you can stay for headache yoga.